part 2 of our series on DVT. I know, it is hard hitting. Let me tell you, if you're the person who has the blood clot, you care a lot about this. So what I want to talk about is when we treat somebody, or anticoagulation is what we call it. The initial phase of the blood thinner medicine is to stabilize the clot and to prevent it from getting any larger or from breaking off and going somewhere else in your body, because that can be very, very bad if it happens. So we initially get someone on medication and get them stabilized. Then we go to the maintenance phase, which is where it keeps the clot stable, but then the body eats up that clot on its own. It's called intrinsic thrombolysis. So, yay, we're getting the clot eaten up and things go back to normal. Hopefully there's not much blood vessel damage, and then we just move on about our lives. Some people need to be on medicine long term. Usually 3 to 6 months is the original time frame of keeping someone on an anticoagulant or a blood thinner medication. People who need secondary prevention long term, they may need to be on medicine the rest of their lives. The major risk with anticoagulation or blood thinner medicines is bleeding. So we have some people that we absolutely do not want to use blood thinner medications on. People who have an immediate surgery planned with a high risk of bleeding. If that surgery can't be prolonged, then no blood thinners for you. People who have severely low platelets, people who have active bleeding somewhere in their body, people who have a hemorrhage in the brain or the spinal cord. These can potentially be devastating. So in those cases, people will get inferior vena cava filters. It's just a little filter that sits in that big blood vessel and catches clots before they can go to important structures. Now, there are some people who we would consider to be relative contraindications, meaning, we wouldn't be crazy about putting them on blood thinners, but it might be safer than just leaving the clot alone, or the Greenfield or inferior vena cava filter. Those are people who have planned surgery with a lower bleeding risk, people who have what we would call a AAA or an abdominal aortic aneurysm, people who have a history of aortic dissection, especially if they don't have their blood pressure under control, people who are at otherwise increased risk of having severe catastrophic side effects from bleeding. The list goes on, but those are some of the biggies. Other risk factors we have to take into consideration when considering whether or not to anticoagulate somebody are older age, low platelets, history of a bleeding disorder, stroke, active cancer, alcohol use, frequent falls, or anemia. Most of the time, treatment is going to be at least 3 months in these cases. One of the great things about anticoagulation these days is dramatically different than when I was in training back just after the Earth's crust cooled, is that most of the time, blood clots can be managed at home or in the ambulatory setting. Back when I was in training, people had to go in the hospital and just sit there for 5 days until their blood thinner kicked in. They would get heparin until their Coumadin or warfarin kicked in. So these medicines that we have now work much more quickly. They can be pricey, so there are drawbacks, but pricey medicine is still a lot cheaper than just cooling your jets in the hospital for 5 days. So I'm talking about medicines like Eliquis or Xarelto or Pradaxa. Usually cardiologists especially like Eliquis and Xarelto better because they have loading doses, and so you can start someone on them and continue them for the entirety of their treatment. If those aren't an option for somebody, then we still do use warfarin, aka Coumadin. It takes 5 days for it really to get in your system, and one of the drawbacks to it is that you have to monitor these patients to make sure that you have them on the right dose. And so sometimes getting them on their regimen can be a little bit complicated, and then especially early on, you have to monitor their ProTime or INR pretty frequently to make sure that you haven't overshot it, because you want your blood kind of like Goldilocks. Not too thin, not too thick, just right. For people who are on long-term anticoagulation, they may need to change their blood thinner if they do have a procedure planned. And in that case, we bridge those people with low molecular weight heparin, also known as Lovenox. To be continued on that, you're going to get to see our special guest get a dose of Lovenox.